Welcome back, everybody. Ready to dive into some digestive procedures today?
Always ready. Sounds like an interesting deep dive.
We're going to be focusing on hernias and colonoscopies today, plus all those coding guidelines for scopes.
Ah, yes, scopes. It's important to know the difference between a diagnostic scope and a surgical scope, right?
Exactly. And we've got our trusty MCG as our guide, the Absolute Medical Coding Guidelines Manual.
It's like having a map to navigate the sometimes confusing world of medical coding.
Okay, let's jump right in with those scopes. I used to think a scope was just a scope, but apparently there's more to it, huh?
Right, so you have your diagnostic scopes, they're used just for looking around, observation. Then there are surgical scopes, and those are used to actually do stuff during the procedure.
Okay, so like taking biopsies or removing polyps, stuff like that.
Exactly. And, this might seem obvious, but it's important to remember that you code the surgical scope.
So if they use both kinds during the same procedure, you only code the surgical one.
Yep.
You only code what's doing the work. Like if you go fishing, you don't bill for the fish finder and the fishing rod.
Right. You only bill for the one that gets you the fish. Makes sense.
Now, there is one exception to that rule. If a diagnostic scope is used during an open procedure, then it can be coded separately.
Oh, that's interesting. So give me an example of when that might happen.
Sure. Let's say a surgeon is doing an open surgery to remove a section of the intestine. And during that surgery, they use a diagnostic scope to take a look around. Maybe check the surrounding area, maybe double check to make sure they got everything. In that case, you'd code both the open surgery and the diagnostic scope.
Gotcha. So it's all about those specific details.
You got it. And speaking of details, we need to talk about colonoscopies and all those modifiers.
Yeah, modifiers, like 53 and 52. Those always seem a bit mysterious.
They're like little flags waving, giving us extra information about what happened during a procedure. So modifier 53.
What's the story behind that one? Modifier 53 is used when a procedure has to be stopped early for reasons outside of the physician's control. Like, let's say during a colonoscopy, the patient's blood pressure suddenly drops really low. The doctor would have to stop the procedure right away for the patient's safety.
Yikes. Makes sense, though. Safety first.
Absolutely. And in that situation, you'd use modifier 53 to indicate that the procedure was discontinued, not because of anything the physician did, but because of circumstances beyond their control.
Got it. So it's all about accurately documenting what happened. No blame, just facts.
Exactly. Now, modifier 52 is a little different. That one's used when a procedure is intentionally reduced in scope.
Okay, what would be an example of that?
Well, imagine a patient is scheduled for a colonoscopy with polyp removal, but during the procedure, the doctor finds out those polyps are just too large to remove safely with a colonoscope.
I see. So they'd have to switch to a different procedure then.
Right, and in that case, you'd use modifier 52 to show that the original colonoscopy was intentionally stopped short.
So it's like hitting the pause button and adjusting the plan based on what's happening in real time.
Yep. Modifier 52 tells everyone that a decision was made to change the course of the procedure. And of course, that affects the coding and billing.
So these modifiers, they add a whole other level of detail to the coding process. It's not just about what procedure was done, but also the why and the how.
Exactly. And all these little details, they matter. They help make sure that patients are billed correctly, that providers are paid fairly, and that medical data is accurate for research and things like that.
It's a complex system, for sure. But I'm starting to see the logic behind it all.
And remember, when it comes to colonoscopy coding, Medicare has its own specific rules and codes. Always a good idea to double-check those.
Great point. Medicare can definitely be a whole other ballgame. All right, so we've talked about scopes and colonoscopies. Ready to move on to hernias.
Let's do it.
You know, hernias, they're kind of fascinating to me in a weird way. Like, there are so many different types. Inguinal hernias, femoral hernias, umbilical hernias.
Yeah, it's like a whole family reunion, and all that variety. That's why it's so important to understand the different types for coding.
Okay, so break it down for me. Why does the specific type of hernia matter so much for coding?
Well, think about it. Each type of hernia, it has its own little quirks, right? And those quirks, they affect how complex the repair is going to be. Take an inguinal hernia, for example. They happen in the groin area, they're pretty common, and usually they're fairly straightforward to fix.
Gotcha. But then you have something like a femoral hernia.
Those happen lower down, in the thigh. And because of where they are, they tend to be trickier to repair. The area is more confined, there's a higher risk of complications,
So the location definitely plays a role. What other factors come into play when coding for hernias?
Well, you gotta know if the hernia is reducible or incarcerated.
Ooh, Those are some big words. Break those down for me.
Okay, imagine a hernia like a suitcase, right? A reducible hernia is like when you can gently push all the clothes back in and zip it closed. Everything goes back to where it belongs.
Okay, I can picture that. So what's an incarcerated hernia then?
That's like when the clothes are jammed in so tight that you can't push them back in. They're stuck.
And that's when things can get dangerous, right?
Exactly. Because
Yeah.
if it gets bad enough, an incarcerated hernia can become strangulated, which means the blood supply to the trapped tissue gets cut off.
And that's a medical emergency, right?
Big time. Needs surgery ASAP.
Wow. So how does all this affect the coding? Like, what's the difference between coding for a reducible hernia versus an incarcerated one?
Oh, it's a big difference. Repairing an incarcerated hernia, or a strangulated one, that's a much more complicated procedure, higher risk too, and the codes reflect that. An incarcerated hernia repair is going to have a higher value code than a simple reducible hernia repair.
I see. It makes sense. It's like the difference between fixing a flat tire and rebuilding an engine.
Exactly. They're both repairs, but the complexity and the skill involved are totally different.
So we've got the type of hernia and whether it's reducible or incarcerated. What other details do coders need to pay attention to with hernias?
Patient age is another big one. Hernias in kids are handled differently than in adults, so the coding is different too. And then you have to know if it's a brand new hernia or if it's a recurrence of an old one.
Because recurrent hernias are trickier to deal with.
Often, yeah. They might need different techniques or materials to fix, so they have their own separate codes.
Wow, it's amazing how much detail goes into coding all these procedures. It's really a whole science unto itself.
It really is, and we've only just scratched the surface here. There's a whole lot more to explore.
Well, I'm definitely ready to dive deeper.
You know, it's kind of mind-blowing when you think about it. These coding guidelines, they might seem like tiny little details, but they have a huge impact on the whole healthcare system.
Okay, I'm all ears. Tell me more about this big impact.
Well, for starters, accurate coding makes sure that hospitals and doctors get paid properly for the work they do.
Right, it's all about making sure the money is flowing where it's supposed to.
And making sure that patients aren't getting overcharged or billed for things they didn't actually get.
So it's kind of like a checks and balances system for the financial side of healthcare.
Exactly. But it goes beyond just the money. Accurate coding, it's also super important for medical research and for public health initiatives.
Okay, now that's interesting. How does coding tie into all that?
Well, think about it. When medical procedures are coded correctly and consistently, researchers, they can use that data to look for trends, see how effective different treatments are, and understand how common different health conditions are.
So it's like each code is a little piece of a giant puzzle.
Yeah.
And by putting all those pieces together, we get a better picture of what's going on in the world of healthcare.
Exactly. And having that big picture, it's crucial for making good decisions about healthcare policy, research funding, you name it.
Wow. I never thought about it like that.
Huh.
It's like a domino effect. It all starts with accurately documenting a single procedure, and then it ripples outward, influencing the entire system.
You got it. And that's why it's so important for coders to know their stuff. Not just the codes themselves, but also the anatomy and the procedures behind those codes. They need to be able to see the big picture, connect the dots.
Speaking of connecting the dots, let's get back to hernias for a minute. We talked about the different types and about how important it is to know if a hernia is reducible or incarcerated. But I'm kind of curious about the actual repair process. Like, what are the different ways to fix a hernia, and how does that affect the coding?
Great question. There are actually several different techniques for hernia repair. And yeah, each technique has its own set of codes and considerations. And which technique they use, well, that depends on a few things, like what kind of hernia it is, how big it is, the patient's overall health, and what the surgeon prefers.
Okay, so give me a crash course in hernia repair techniques.
All right, so one common approach is called a herniography. And basically, that involves sewing the edges of the weakened muscle or tissue back together to close up that hole.
So it's like sewing up a tear in a piece of fabric.
Yeah, exactly, just reinforcing the weakened area. Now, another common technique, that's called a hernioplasty. And with this one, they use a mesh patch to reinforce the weak spot.
So it's kind of like putting a patch over a hole in the wall.
Yep. That mesh, it acts like a reinforcement to prevent the hernia from coming back. And usually they'll use a hernioplasty for larger hernias or ones in areas where the tissue is kind of weak and might tear easily. That mesh adds some extra strength.
And I'm guessing the coding is different depending on which technique they use.
Oh yeah, absolutely. Each technique has its own specific codes, and those codes reflect how complex the procedure is and what resources are used. Like if they do a laparoscopic hernia repair, which is minimally invasive, that's going to have different codes than an open repair.
So it's like a choose-your-own-adventure book for hernia repairs. Different paths, different codes.
I like that. And just like in a choose-your-own-adventure book, each decision along the way matters. It changes the outcome.
Speaking of decisions, let's switch gears for a minute and talk about intestinal transplants. I always found those really interesting. Like, what determines whether someone even needs a transplant in the first place?
So intestinal transplants, they're usually only considered for patients with something called Oh, definitely not. It's a big decision, and it's made by a whole team of specialists. Gastroenterologists, surgeons, transplant coordinators, social workers, everyone's involved. They look at the patient's entire medical history, their overall health, their support system, everything, to decide if a transplant is the right way to go.
It's a really holistic approach. It's not just about the medical stuff. It's about the patient's whole life.
Exactly. They want to make sure the patient is ready for the challenges that come with a transplant, both physically and mentally, and that they'll be able to handle the long-term care afterwards.
Now, I'm curious about the actual transplant procedure. What are the main steps involved, and how do those translate into coding language?
Well, the whole transplant process, it's like a perfectly choreographed dance. Every step has to be done just right. And the first step is finding a donor, a good match. That means matching blood type and tissue type so the recipient's body doesn't reject the new organ.
Rejection, that's when the body's immune system attacks the transplanted organ, right?
That's it. So once they find a donor, they carefully remove the organ and get it to the transplant center. Then the recipient has surgery to remove their diseased intestine and replace it with the donor organ.
It's amazing that we can even do that,
Yeah.
like transplanting an entire organ.
It really is. And the coding for intestinal transplants, well, it's just as complicated as the surgery itself. There are specific codes for every single part of the process, from taking the organ from the donor to the actual transplant surgery to the care the patient gets afterwards, including the medications they need to prevent rejection. It's a whole lot to keep track of.
It's like its own language,
Yeah.
a language for saving lives.
You could say that. And knowing that language, well, that's how transplant centers get paid for all the incredible work they do.
I gotta say, I have so much respect for everyone involved in these transplants, the surgeons, the coders, everyone. It's truly incredible what they can do.
I agree. It's really inspiring to see how dedicated and skilled these people are, and to see how these procedures can completely change a person's life.
And speaking of changing lives, I think it's safe to say that our understanding of digestive procedures has been totally transformed by this deep dive. We've come a long way from thinking about scopes and colonoscopies and hernias as these simple things. Now we see how complex and nuanced they really are, how much detail goes into diagnosing them, treating them, and coding them.
It's been a real eye-opener, hasn't it? And honestly, we've only just scratched the surface. There's so much more to learn.
Well, I'm ready for more. Let's dive into the last part of our deep dive and see what other discoveries await. Welcome back for the final leg of our digestive procedure deep dive. It's been quite a journey, hasn't it? From scopes to colonoscopies to hernias. I feel like I've learned a ton.
Me too. It's amazing how much there is to know about these procedures, and we haven't even touched on everything.
Speaking of learning, I wanted to circle back to our trusty guide for this deep dive, the MCG. The Absolute Medical Coding Guidelines Manual.
Ah, yes, the MCG. It's like a secret decoder ring for medical billing and coding.
Exactly. And I think it's worth highlighting again that even if you aren't a coder, having a basic understanding of these guidelines can be incredibly helpful. Imagine getting a medical bill and seeing all those codes and they just look like gibberish, right? Well, with the MCG, you can actually look up those codes and understand what they mean. You can see what procedures were done and why you're being charged certain amounts.
It's all about transparency and empowering patients, giving them the tools to understand their healthcare journey and their medical bills.
So it's like having a secret weapon when you're dealing with the often confusing world of healthcare.
Exactly. It can help you advocate for yourself and make sure you're being billed correctly.
Now, before we wrap things up, I wanted to leave our listeners with something to think about, something that kind of ties into everything we've talked about today.
Okay, I love a good challenge.
So we've talked a lot about how important these coding guidelines are for accuracy and consistency. But what happens when new procedures come along or new technologies? How do the guidelines keep up with all the advancements in medicine?
That's a fantastic question, and it really gets at the heart of what makes medical coding so dynamic. The truth is, the field is constantly evolving. There are always new treatments and technologies being developed. It's like trying to hit a moving target.
So the guidelines have to be flexible and adapt to all those changes.
Exactly. The organizations that are responsible for maintaining the guidelines, like the AMA, they're always reviewing and updating codes to reflect the latest medical practices. It's an ongoing process to make sure the coding system stays relevant.
So it's like a living language, always changing and evolving.
That's a perfect analogy. Medical coding is definitely a living, breathing language.
Well, on that note, I think it's time to wrap up our deep dive into digestive procedures. I hope you all found it as fascinating as I did.
It's been a real pleasure joining you on this journey.
And remember, even though we've come to the end of this particular exploration, the quest for knowledge never really ends. There's always something new to learn and discover about the world around us.
Absolutely. Stay curious, everyone. Keep those questions coming and keep diving deep.
Until next time.